Hello, everyone, and welcome to episode 5 of season 2 of this APSC-EECC Core Cardiology Review series. My name is Aaysha Cader, and today our episode is on coronary artery disease. Next slide, please. So the Asia Pacific Society of Cardiology, in collaboration with the European Examination in Core Cardiology, or the EECC, presents this Core Cardiology Review, which is a webinar series designed to provide comprehensive updates on a variety of core cardiology topics. It's also really useful as a preparatory for cardiologists in the Asia Pacific region planning to take the EECC test. I am delighted to be joined by some fantastic core course directors led by Jonathan Yap from Singapore. We have Dr. Vishnu Aditya from Indonesia, Esman Sharif from Malaysia, and Wei Tin Shang from Taiwan. And we have the expert advice of Prof. Jack Tan from Singapore, who is also co-chairing this session with me today, and Prof. Chris Plummer from the UK. Next slide, please. As you know, our chairs today are I'm joined by Prof. Tan, as well as Dr. Shibba Takkar from India. Next slide, please. And we have two fantastic talks, which will be done by two speakers. Dr. Upul Wickramarachchi from Sri Lanka will speak on acute coronary syndromes, and Dr. Jeremy Quah from Malaysia will give us an overview of chronic coronary syndromes with an objective of preparing for the EECC. Next slide, please. Just some housekeeping rules. The content of this webinar is copyrighted by the APSC. The views and opinions expressed are those of the faculty members and do not necessarily represent those of the APSC. This webinar is also live streamed via APSC Facebook and YouTube pages and will be available later on for you to review as well. And you will receive your certificate of attendance upon completing a survey, which is sent via email after the webinar. Please also engage in the question and answers. We will be happy to take questions. Put in your questions in the Q&A box at the bottom of the screen, as you can see. Next slide, please. A quick shout out to the next webinar on this series, which is episode 6 on the 12th of February. Again, same time on Wednesday, Singapore time, 6 p.m. This will be on cardiac rehabilitation and prevention. Next slide, please. And also, we'd like to invite you to join us in Busan for the EECC preparatory course on the 17th of April. It's a full-day course with fantastic faculty and covering the whole range of topics. Make sure you take advantage of the early bird free, which is until the 20th of February. Next slide, please. All right, so without much ado, let's get started. I'm delighted to invite our first speaker, who is Dr. Upul Wickramarachchi, a consultant cardiologist at Lanka Hospitals in Colombo, Sri Lanka, who will speak to us on acute coronary syndromes. Over to you, Upul.
Thanks very much, Aaysha, and thanks for the opportunity. It's a great honor. Let me share my slides. Right, can you all see my slides?
Yes, we can.
Okay, great. Well, good afternoon or good evening, depending on where you're joining from. As I said, I'm Dr. Upul Wickramarachchi from Colombo, Sri Lanka. So I'll be talking about acute coronary syndromes. So, I mean, to give a brief introduction, ACSE is the acute phase of ischemic coronary artery disease with or without myocardial cell necrosis. And it represents a big spectrum from mild chest pain that's part of unstable angina to a cardiac arrest. And then it's a working diagnosis on admission and which will be refined depending on the investigation findings, such as ECG and troponins. Just to give very brief things, briefly on epidemiology, still the #1 killer, 1/3 of deaths, 7.5 million due to ischemic heart disease. And men get ACS 7 to 10 years earlier than women. Less than 60 is mostly men, but when it comes to over 75, it's mostly women. The two graphs showing that it's a single most killer still compared to other causes. In terms of European data, the worst mortality is in Estonia and Latvia, and best mortality figures are from Sweden and Poland. So today's talk mainly will be based on ESC ACS guidelines 2023, and I'll be going through basically the physical examination, investigations, treatment, and on treatment, important timings, the initial treatment, stabilization, repurposing strategy, antithrombotic therapy, and then a little bit about technical details in hospital management, complications, and long-term management. So clinical presentation and investigation. So I'm not going into detail about symptoms of acute coronary syndrome. If you really want to read through this, it's bread and butter. But if you still want to read through, there's supplement material on the guidelines, which you can have access to. History, thorough history and physical examination is very, very important. And simultaneously, we get the ECGs done together with other blood tests like troponin. So depending on the history examination and then the ECG findings, we can categorize them onto which path the patient is going to go under. So if there's ST elevation, he or she would be managed as the STEMI pathway. If there's no ST elevation, then on the non-ST elevation pathway. And if there's got very high risk features, probably just like primary, STEMI pathway, but if there's no very high risk, then the further risk stratification, which we'll be talking about later on. So these are the guideline tables. ECG, of course, history examination is recommended, and then ECG under 10 minutes, and interpret them most importantly. If you're suspecting complete occlusion of an artery, but ECGs equivocal, you can always look for other evidence such as V3R, V4R, and V7, V9 to reveal right ventricular or posterior ischemia. Then blood sampling, what's recommended is 0 and 1 hour. You can do 0, 2 hour as well. And then if the inconclusive, you can do a 3-hour one as well, excuse me. And then, of course, use a Brace score. So first two, will be helpful to rule in, rule out. And in uncertain ones, the third one will also be helpful. Excuse me. So same things, just going through. Clinical presentation could be from just not so severe chest pain to a cardiac arrest. ECG findings could be from normal ECGs to ST elevation to ST depressions to malignant arrhythmias. Working diagnosis initially either 2, and depending on the troponin and other things, we'll be classifying them under unstable angina, non-STEMI or STEMI. And of course, there is another set of patients who will not fall into any of these as well, which we will talk about later on. This is pretty much the same thing. As I said before, patient get troponin at presentation and in 1 hour or 2 hours, depending on the institution policy, but ESC would prefer 0 and 1 hour. And there's 2 paths, that's rule out path. If troponins are negative, 1 hour, 0 and 1 hour, and if the history examination ECG troponins are suggestive that now this is not ACS, then there's rule out pathway. Then there is a rule in pathway when the troponins are positive together with other findings. There's always a hazy group people where the history is not so straightforward, and the troponins could also be a little difficult to interpret. And these patients you would keep under observation, and you'll have to consider excuse me, other differential diagnosis. This is a long list, but very important from both from patient management as well as exam point of view. Cardiac causes commonly myopericardite, the cardiomyopathies, Takotsubo, and then pulmonary embolism. Anterior T-wave inversions could be mistaken for anterior ischemia, whereas it could be right heart strain due to pulmonary embolism. Then vascular aortic dissections, if there are neurological features, together with the radiofemoral delays or pulse deficits, and also with the way the symptoms are described, you should keep an open mind about these things. Gastrointestinal, I'm sure you would have come across perf dural ulcers being presented as ACS with a small troponin rise. So always a little feel of the abdomen, make sure it's not cholecystitis or other gastrointestinal problems. So keep an open mind about differential diagnosis. Echocardiogram, excuse me, is very helpful in the diagnosis process. I mean, if it's definitely indicated in cardiogenic shock, but in other situations, it should not delay, especially in primary PCI setting, it should not delay further treatment. When they're in the middle path I showed previously, when the TROP's negative, or when they're in a non-conclusive path, incorporating a CCTA could be helpful in determining getting a diagnosis. But routine CCTA is not recommended. They mark the word routine there. So if we go to ST elevation MI, the treatment now will depend on first medical contact, where they're presented to. And if it's primary PCI center, the aim is for a diagnosis to wire time of less than 60 minutes. If it's a non-PCI center, and if the primary PCI is available under 120 minutes, that's 2 hours, we aim for a wire to diagnosis to wire time of less than 90 minutes. And if they're not if they don't have access to the primary PCI center under 120, then you should consider fibrinolysis or thrombolysis, and diagnosis to needle time of less than 10 minutes is what's recommended. Initial stabilization, oxygen therapy when saturations are less than 90%, it's no longer recommended when saturations are more than 90. Intravenous opioids, nitrates, all these mild tranquilizers can be given. And intravenous beta blockers, if they're not in heart failure and with good blood pressure and heart rate, are recommended in form of IV metoprolol to reduce the reduce risk of arrhythmias as well as microvascular obstruction. So key points. Primary PCI is the treatment choice when presenting less than 12 hours of symptom onset. Thrombolysis if diagnosis to wire time is more than 2 hours. Thrombolysis should be done when presented within 12 hours. As you know, the longer you leave from presentation or symptom onset, the benefits of thrombolysis would be less. So that we have to keep in mind, and diagnosis to needle time of less than 10 minutes. If failed thrombolysis, i.e. less than 50% ST resolution in 60 to 90 minutes, ongoing chest pain, worsening ischemia, electrical hemodynamical instability, rescue PCI should be considered. Excuse me. And patients who have been successfully thrombolized should be transferred immediately to a PCI center with the aim of having an angiogram within 2 to 24 hours from the injection of the fibrinolytic agent. And if patients present more than 48 hours from symptom onset, routine PCI to the IRA is not recommended. Presenting between 12 and 48 hours, routine PCI still may offer some benefit. Fibrinolytics, it's the same thing. So we've just gone through aim for less than 10 minutes if you're doing it. Tenecteplase, alteplase, or rituplase is recommended. Half dose if more than 75 years of age. Co-administered with antiplatelets, and also enoxaparin IV and then subcutaneously. And if treated with streptokinase IV bolus, 100 pounds followed by a SIG, it should be considered. That's later on. And if the diagnosis is made in the community by a capable crew, fibrinolysis should be considered pre-hospital to reduce mortality, and is being advocated. It's good to know the absolute and relative contraindications, ICH, ischemic stroke in 6 months. There's a whole host of things, central nervous damage or arterial malformations, major trauma, GI bleedings, aortic dissections, of course, and non-compressible punctures such as liver or lung biopsy and those things, lumbar punctures, and then relative contraindications such as uncontrollable blood pressure, advanced liver disease, active peptic ulcer, TIAs. It's good to know these things. They might for clinical practice as well as from exam point of view. So in terms of revascularization or reperfusion, emergency bypass is also a possibility if there's if the IRA is patent and the anatomy is not suitable for PCI, or if there are large myocardial area that's in jeopardy. With MI-related mechanical complications who need revascularization, then CABG should be is recommended at the time of the surgical repair. STEMI patients with failed PCI or with an acute coronary occlusion not amenable to PCI, emergency CABG should be considered, but with, of course, higher risks. Excuse me. So this is the same things on the table that we've been discussing so far. I don't think there's anything that's new here that we have not discussed. So routine PCI of an occluded IRA not recommended in STEMI when they're presenting more than 48 hours of symptom onset. 12 to 48 hours still offer some benefit. Yeah. And fibrinolysis should be considered when it's less than 12 hours of onset. So patients, that's for STEMI, and if you're going down the non-STEMI path, an invasive strategy is recommended unless there's an absolute contraindication. Immediate invasive strategy is recommended when there's any very high risk feature, and early, that's within 24 hours, recommended when there's high risk feature. So that's to get an idea about which path. So at the topmost, if you find very high risk features, they are treated just like a STEMI as primary PCI for immediate angiography, hemodynamic instability or cardiogenic shock, recurrent ongoing chest pain refractory medical treatment, acute heart failure due to the MI, life-threatening arrhythmias, mechanical complications, recurrent dynamic exchanges, or cardiac arrest. And then the high risk features, those are the very high risk. High risk features necessitating angiography within 24 hours, confirmed diagnosis, non-STEMI, gray score more than 140, transient ST elevation, dynamic ST changes. And the others, we have some time to think about the benefits and risks versus benefits of angiography, depending on their comorbidities, frailty, and other factors. These are the same things on the table, the very high risk features and the high risk features. We just gone through them. So coming on to antithrombotic therapy. Excuse me. Now, this is a cornerstone of the management of acute coronary syndrome, as you know, which has made a massive difference in patient outcomes in the last 2 to 3 decades since their introduction. So the commonly used good old aspirin, the thromboxane A2 inhibitor, and then the P2Y12 inhibitors that we are known to have, clopidogrel, ticagrelor, prasugrel, and the cangrelor, the red ones are the ones that could be given IV. Factor 10 inhibitors, fondaparinux, UFH, enoxaparin, and then anticoagulants, bivalirudin, apixaban, and edoxaban, and thrombin inhibitors, dabigatran, and bivalirudin. So knowing where they work and the different roles will be very helpful from a clinical perspective as well as an examination point of view. They're when to use with their loading doses, we should know them. Aspirin, as you'll know, load with 300 and then maintenance dose of 75 to 1 to 5 or 100. Clopidogrel load with 300, 600. Usually, it's primary, we load with 600 and then 75 maintenance. Prasugrel loading with 60. Maintenance with 10. If they're less than 60, we load with 5. And if the age is more than 75, then to be used with caution. Ticagrelor, we load with 180 milligrams and maintenance of 90 BD. Cangrelor can be given bolus of 30 mics per kg, followed by 4 mcg per kg permanent infusion. Then the GP2B3A inhibitors, not used pre-PCI now, unlike those days. Eptidide and tirofiban can be initiated during PCI and also can be run as an infusion afterwards. Anticoagulants, unfractured heparin is the most commonly used one, especially during PCI and pre-PCI, 70 to 100 units per kg. Enoxaparin, the subcut dose is 1 milligrams per kg BD, and if you're using IV, 0.3 milligrams per kg. Bivalirudin and as well as fondaparinux. Fondaparinux is 2.5 milligram dose once-a-day dose of fondopyrox. Right, so when to use anticoagulants, antiplatelets, and all those with regards to different scenarios. So if it's primary PCI, unfractionated heparin, and then also an enoxaparin or bivalirudin can be used, but not fondopyrox. In non-ST elevations, if angiography is planned within 24 hours, it's unfractionated heparin or enoxaparin, but fondopyrox is only if the angiography is planned after 24 hours. In terms of antiplatelets, aspirin and P2Y12 inhibitors in the setting of primary PCI can be used even as preloading. But if it's a non-ST elevation MI that we plan to angiography under 24 hours, then P2Y12 inhibitor is not recommended as a loading dose, as preloading anymore. Then, in terms of invasive coronary angiography, prasugrel and ticagrelor is preferred to clopidogrel if it's available and can be tolerated. And if proceeding with PCI, prasugrel is preferred to ticagrelor. And duration of DAPT is 12 months usually, and after 12 months, it's single antiplatelet. Of course, there are caveats to these, which we'll cover some of them later on. So basic recommendation is pretty much the same things that we've just gone through in tables. So as I said before, if the not to do ones are the pre-treatment with GP2B3A pre-treatment is not recommended anymore, and routine pre-treatment with P2Y12 receptor antagonist in non-ST elevation MIs in whom coronary anatomy is not known and early invasive angiography is planned, that's not recommended anymore as well. But P2Y12 in the setting of STEMI can be still used as preloading. Anticoagulants, we've gone through these as well. We mentioned this as well. What not to do, fondopyrox is not recommended in patients with STEMI undergoing PPCI. We've discussed that. I think other things, combining it with oral anticoagulants. So if STATS-FAST score is more than 1 for men and more than 2 for women, equal 2 or more for women, you can use TAT, triple antithrombotic therapy for a week, and then downgrade. We'll go through this in detail later on. So antiplatelet strategy and downgrading them as required in high bleeding risk. This is also a very common question topic as well as in our day-to-day clinical practice. If high bleeding risk patients, after 1 month of DAPT, we can go down to single antiplatelet, P2Y12 aspirin monotherapy. In high bleeding risk patients or non-HBR patients, if there's been no clinical events after 3 months also, we can consider that depending on ischemia and bleeding risk, versus bleeding risk, even after 6 months also, we can do this downgrading. And P2Y12 inhibitor, if it's a potent one like prasugrel or ticagrelor, that can be downgraded to clopidogrel after 3 months. Use of antiplatelets with oral anticoagulants. Excuse me. So default strategies, TAT or triple antithrombotic therapy, that's oral anticoagulant plus DAPT for usually 1 week. And then up to 6 months, it's DAT dual antithrombotic therapy. That's an oral anticoagulant and a single antiplatelet. And then from 6 months to 12 months, we could have 2 approaches. One that's DAT and also just the oral anticoagulant therapy if the ischemic risks are accepted or bleeding risks are high. And then after 12 months, it's just oral anticoagulant. To reduce ischemic risk, then TAT can be continued up to 1 month, downgraded to DAT, that's oral anticoagulant plus single antiplatelet, and then after 1 year again, just monotherapy with an oral anticoagulant.
We have about 5 minutes to go, Upul.
Okay,
sorry,
right,
Upul, we have about 5 minutes.
Okay. So in hospital management, first 24 hours in CCU can be discharged 48 to 72 hours, both primary PCR, ST elevation and non-ST elevation MI patients, provided they are stable. And then technical aspects, a little bit on the technical aspects. If the clear-cut lesion is clear-cut, intravascular imaging is class 2A recommendation. If it's not clear, then of course it's recommended OCT to be indication of IVUS. And depending on what you find, whether it's CAD or no lesion or calcium nodule, you can tailor-made. The management could be tailor-made. Radial access is preferred. PCI with IRA in this procedure is recommended, and then drug-eluting stent is a recommended guideline recommended therapy. The routine use of thrombus aspiration is not recommended, but we can use in selected patients. Multivessel disease, if it's cardiogenic shock, immediate PCI to IRA only, and stage later on. STEMI, complete revasc at the time of the index procedure or within 45 days. If it's non-ST elevation, I might try to do it at the index procedure. And functional invasive assessment can be helpful or can be used. MINOCA, we should know about MINOCA, their common causes, and the diagnostic approach. There's a big list. And then we come to that middle part patients where we have to think about differential diagnosis if we cannot find an obvious cause. Coming on to complications of ACS, cardiogenic shock, immediate PCI with 2 IRA is recommended. If not, it can't cabbage. Then the routine use of IABP is not recommended anymore, but that's marked the word routine, can be used in specific clinical scenarios, especially if there's mechanical complications. In terms of mechanical cardiac support devices, still the NVEC or the evidence is not very clear, so there's no strong supporters from the guidelines, but we know they're being used increasingly. The complications are rare because of the prevalence of PPCI, but if there's mechanical complications complicated with shock, then IABP has got a place. LV thrombus detected mainly on echo, cardiac MRI, anticoagulation with VKO, not recommended. The other complications like atrial fibrillation, ventricular arrhythmias, bradyarrhythmias, those we should know. Treatment goals in terms of lifestyle modifications, taking drug compliance, and knowing their numbers, the blood pressure less than 130, systolic diastolic less than 80, LDL of less than 55, HbA1c of less than 7. Those are things to patients should adhere to, and we as clinicians should promote. And the other medications, beta blockers, ACE inhibitors, if EF is less than 40, the mineral MRAs, polypills if available, vaccination, and then not forgetting the colchicine as an anti-inflammatory agent to reduce further adverse events. So make sure that they are on all the right treatment at the time of discharge. And then patient education, for how they can improve their health in the long term, not stopping smoking, to eat healthy, avoid alcohol, exercise, and relieving stress, medications, follow-up appointment, and knowing their numbers. So that's like basic overview of quick overview of the guidelines, covering some of the core curriculum as well. Yeah, I mean it's I hope it was not too fast, but tried my best to cover most things. That's
Thank
about
you.
it, and I'm open to questions. Yes.
Thanks very much, Upul. I'd like to request the audience to please put their questions in the Q&A box. There's quite a lot to cover, but I guess from an EECC perspective, exam perspective, in terms of ACS, the majority of questions are usually centered around the timing of each next intervention. So a patient comes in with chest pain of 3 hours. What would you do next? What would you do next? And especially the time cutoffs for PCI. Another thing, Upul, maybe I could kick off with the questions is patients with out-of-hospital cardiac arrest. So an out-of-hospital cardiac arrest in an absence of ST elevation on ECG, how would you manage? That's the kind of question that can also come up.
The routine angiography is not recommended anymore, unless there is ST elevation, yes. Yeah.
Prof. Tan, Dr. Shibba, if you feel free to chip in with your
Shibba, any
experiences.
comments? Upal, maybe you can stop share your screen.
Can I
Yeah.
share that? So if anyone needs to chill after the exam, they can come here.
Yeah.
Thank you. Thanks.
So I think it was really an amazing session, and so many points, they were reviewed fast. I would like to have the comments of the house. We know that the guidelines, they say that in patients with acute coronary syndrome and those who have indications of receiving an oral anticoagulant or NOAC, after a week, and, we have a pathway which is there. Are the guidelines anyways different in the patients of acute coronary syndrome who has received a PCI and a stent vis-a-vis a patient who is not received? Because placing a patient on a NOAC monotherapy and not giving an antiplatelet at all in a patient who has a base of a stent is one thing which has always intrigued the minds. And so I would like to have the comments from you and the house. Though guidelines, yes, they do say that monotherapy that is what is indicated after 12 months of therapy.
Sorry, was the question to me?
The
Yeah.
question
no,
is,
mine-
I just
sorry.
clarify, the question is about
Yeah, so
the
my
duration
take
of DOAC.
Yes.
Yeah.
my take would be after 12 months, of course, as the guidelines recommend monotherapy, but we can always use the high ischemic risk criteria that have been laid down, such as, 2-stent bifurcation stenting, stents more than 3 stents, length of more than 60 millimeters, prior STEMI, prior stent thrombosis while on dual antiplatelets. Those criteria to help in management. I think guidelines are guidelines, but yes, I think we have to deal with the patient that's in front of us. That's
We have one question. Thanks, Upul. We have one question from the audience, and I think it's very relevant. Perhaps Prof. Tan can take this. They say, we know that PCI of IRA is not recommended beyond 48 hours if it is occluded, not if there is flow, it doesn't tally. If it is an occluded artery as per old trial. So the question is, how should we manage patients who present after 48 hours? Prof. Tan, perhaps we could weigh in on your expertise.
Yeah, the evidence in the OATS trial was actually fairly clear that you really have an infarcted artery, patient is asymptomatic, and the artery is occluded. Trying to open it actually causes more harm. So I would say we should follow the evidence. And if you think that it's a large enough territory and there was pretty good collaterals, and then look at it from that angle, and the collateral extend back up and there's still blush on the collaterals, I would still try to open it. That's during the procedure itself. If not, I think we should further re-stratify and make sure the territory is viable, and there's no harm then to wait out with a period of medical therapy before you re-stratify the lesion and ischemia. I would follow the evidence. I just make a few comments. I think the very difficult lecture that Upal gave, because it covered too much ground over 20 minutes. For the purposes of the exam, please, the fellows, you have to study in those pockets: diagnosis, management in terms of invasiveness, timing, and then the pockets of the questions of the drug duration, balancing ischemic and bleeding risk. And all these are very important, but in the Asian context, there's a lot of variation between what is in the European guidelines and what we practice in Asia. Even simple things like diagnosis, where high sensitive troponin is still not widely available and used. We don't use CT angiogram for our ED patients in a lot of EDs in Asia. And the practice of not preloading for NSTEMI before bringing the cath lab for early invasiveness is probably not widely practiced in Asia as well. And there's still a lot of thrombolysis happening across Asia Pac for STEMIs as well. And the practice for opening up infarct-related arteries in cardiogenic shock alone, I would say, is still quite variable practice. So there's a lot of practice differences. For the purpose of exam, please follow the guidelines. That's all I can say. Thanks, Aaysha.
Yeah.
Thanks, back to you.
Thanks, Prof. Tan. I think you raised a
Thank
very
you.
important point about the revascularization. I think, especially given the new trial updates from Complete 2 and Multistars, that's another aspect in the EECC exam. They will ask you make sure you study up the new trials that are informing updates to the guidelines, because that is something they will also cover. So related to this, Complete 2, Multistars, AMI, BioVasc, those are the trials. And I think a question might be about complete revascularization in the setting of shock, as Upul showed. It's only the culprit artery that's recommended in shock, but if it's not shock, it is a class 1 indication to do complete revascularization within 45 days of the index procedure. So it can be at the index, it can be before discharge, it can be even after. So those are some important points. We do have another question about if we were to use triple therapy for ACS and AFib, and this is a very important aspect of the questions related to the exam as well. Which NOAC would you use if you use triple therapy, or can you use any NOAC? Upul, perhaps you could take that.
Okay, it probably comes to personal. I don't think guidelines from exam point of view, they don't recommend or name NOACs. Personally, I'd like, if I'm going for combination therapy, rivaroxaban, because there are multiple dosing regimens if you need to step down. I don't know.
So I think it's fairly clear in the guidelines, isn't it, that there's no special preference for the NOAC, although there is preference for the P2Y12 inhibitor. It has to be clopidogrel if it's
And clopidogrel should be the probable preferred antiplatelet. Is that right? I think guidelines do mention it.
Yes.
That when and so can we have a quick question on beta blockers and MI, because there have been recent trials as the ABIS trial group, which has talked about beta blockers post MI and, not really the great benefit which occurs, especially once the revascularization has been done. And as Professor Tan just now mentioned, that in Asia, we have an entire, like he said, that we should answer the exam as on the basis of guidelines, but individualizing to our Asian countries where patients are not receiving enough of revascularization, withdrawing these drugs and giving them just in patients with LV ejection fractions, which are less than 40%, is an issue. So can have Professor Tan's, comments on.
Yeah, so I'm not sure whether there's a lot of good evidence for beta blocker if the patient doesn't have heart failure. So I'm not actually very enamored about the routine use of beta blocker, but as you rightly said, it's a very useful anti-ischemic agent if the patient is unrevascularized. So post-revascularization, I think the benefit is minimal, unless the patient has heart failure or clearly tachycardic or AFib.
Yeah.
So I would say minimalizing drugs is a good idea. The evidence doesn't support routine use anyway. Thanks.
Yeah. Thanks.
Thanks for that discussion. Just one last point about secondary prevention, because it came up and I think that's important and maybe an exam question, is the post-MI LDL target, irrespective of anything, is 1.4. So if they should be on high intensity statins. I know in Asia we tend to give atorvastatin 40 or rosuvastatin 10 because our people are smaller, but for the purpose of the exam, it's atorvastatin 80 as a high intensity statin. And if while on that you do not meet LDL targets of 1.4, the next step is to add ezetimibe. So that flow pathway of lipid lowering therapy is also an important aspect from an exam standpoint. So thank you, Upul, for that very informative talk, and thanks for the lively discussion, Prof. Tan and Shibba. Shall we move on to the next talk? Shibba, would you like to introduce our next
yes,
speaker?
yeah, thank you. So after this amazing talk, we have yet another amazing talk by Dr. Jeremy from Malaysia, and he's going to talk about chronic coronary syndromes. All off to you, Dr. Jeremy.
Yeah, thank you, Dr. Shibba. Thank you so much for this opportunity. You can hear me well, and my slides are clear? You guys can see my slides?
Oh, yes, they're very clear. Yeah.
Right, great. So thank you again for this opportunity. Thank you, APSC. It's really a privilege to be here. And let me just start straight away. So my task today will be to talk about the chronic coronary syndromes. So my name is Jeremy, and I'm from Malaysia. And the focus, as Dr. Aaysha mentioned just now, for me would be to help the people who are listening on this to pass the exams as much as possible. Because it's a very wide topic and you have a lot to study. And we all know that cardiologists are just so busy in the labs and our clinics and wards. So we try to optimize our time as much as we can to pass the exams. So this is the Holy Grail. Nothing else. You just have to study this. As Prof. Chair has mentioned, just spend time to study it. But I'm trying to hopefully provide you some insights on how to make your studying a bit more time effective, time efficient, given our busy schedule. So now it's actually quite fortuitous because we have now the latest guidelines 2024. So the upcoming ESC or EECC exams will definitely be focusing on these updated guidelines compared to 2019. So it's important that when you read up on guidelines for the exams, make sure you're reading up the latest guidelines and not earlier guidelines. Here you can see here, and it's very well shown that there's a very nice table. And we have moved on now on to understanding more about the coronaries. It's not just the structural aspect of it, whether the patient has focal or diffuse arteriosclerosis, myocardial bridging, coronary aneurysms, whether the patient has anomalous arteries. And talking about anomalous coronary arteries, of course, is another separate topic, but the EECC, they love to ask about anomalous coronary arteries. So please focus on that, read on that, and on how to manage on different aspects of that. The functional aspect now, we talk a lot about endothelial dysfunction, hyperreactivity, using acetylcholine to test. So all this is important. And you talk about microvascular dysfunction. Microvascular dysfunction, of course, is another topic that is it's a favorite question as well in the ECSMs. So my focus here will be on the chronic or coronary syndrome, as compared to Dr. Upul, as mentioned. We have educated everyone very well on the acute side. So the updated definition is important. It's just to highlight there is a range of clinical presentation syndromes, and basically clinical presentations can vary from being asymptomatic all the way to having LV dysfunction or heart failure of ischemic origin. So they have focused quite a lot on this updated definition. Another interesting aspect to it is because it's the EECC exam, the focus here should be on ESC guidelines. Don't get confused with the US guidelines because things can be a bit different. And as you can see here, these are some of the updated changes in the guidelines. And they will ask you simple things in the EECC. You might be quite surprised. So simple as asking you as syntax scoring and giving you various options about syntax score. If you have low syntax score, if you have high syntax score, what does it mean? And it applies a lot to practice, but as all the panelists has mentioned so eloquently, practical application and practical knowledge is different from the exams. So the exams, you just have to follow what is written, and then you do fine. So another thing to mention is if you have limited time, focus on all the class 1 evidence. So such as this, in chronic coronary syndrome patients, low surgical risk with significant left main coronary stenosis, CVG is the preferred approach and it's class 1 evidence over PCI. In CCS patients with low syntax score, where basically means there's less complex lesions, there's no such thing as simple in coronary angiogram angioplasty, but in terms of exam terms, yes, less complex lesions, PCI can be an alternative to CVG if complete revascularization can be achieved, class 1. And this is very, very clear in the guidelines. The newer guidelines also mentioned about coronary microvascular dysfunction, and it uses, it talks also about using pretest likelihood for obstructive CAD in comparison to the earlier guidelines. So coronary microvascular dysfunction is separate and the obstructive CAD is separate. But for those with low or moderate pretest probability, which I'll talk about it later, showing you a table, they talk a lot about coronary CT angiography recommended to diagnose obstructive CAD. And of course, there were many studies in the past. We talked about trials looking into initial strategy of CT angiography or initial strategy of functional testing. So it's important to follow this as long as you assess the probability or the pretest probability and it's low or moderate. CT angiography has been shown to help us diagnose patients with obstructive CAD and does not actually show increase in the use of invasive coronary angiography, especially in the latest study. And how about patients with moderate or high clinical likelihood of obstructive CAD? Functional imaging is recommended, moderate or severe ischemia. And in the event of no obstructive disease is found, the guidelines advise clinicians to consider angina or ischemia in the absence of non-obstructive coronary arteries. But as Dr. Upul has mentioned also, I think in life and in practice, it's not so simple as just labeling a patient as ANOCA or INOCA. You have to look beyond cardiac origin, which is very, very important. Because you might miss if you just focus on cardiac itself. But in this case, in this exam setting, this is what you should look for. In multivessel CAD, it is more complicated here. It's more difficult. Revascular dilation remains class 1, particularly in patients with EF of more than 35% and functionally significant 3-vessel CAD. In surgically eligible patients, chronic patients with multivessel CAD and poor EF of less than 35% or equal, CABG surgery is also a class 1 recommendation to improve long-term survival over guideline-directed medical care. So this is in contrast to the US guidelines, and the US guidelines rely a lot on ischemic results or ischemia trial. So now there's the ischemia extended trial, and it's important that when you look at trials and you read, memorize the conclusions and simple words like whether there's reduction in cardiovascular mortality, or whether there's increase in non-cardiovascular mortality, or is it morbidity. These are simple words that the exam sometimes can be used. I feel that they use words to sometimes confuse the candidates, but not the intention to confuse the candidates, but more so that we have to be very precise in interpreting trials, right? So I guess that's the idea behind all these exams. We have to be very precise. So we memorize all this mortality, morbidity, and the results of these trials, whether it's neutral or whether it's favoring one side. The GDMT for angina, this is a very favorite common exam question. You can notice here they don't mention about, if you look at the guidelines for GDMT, angina, anti-anginals, ivabradine is very low down the ladder. So always remember your nitrates, your beta blockers, your calcium channel blockers. These are class 1 evidence. And okay, favorite exam question. Guidelines don't specify. And again, common things first. Antithrombotic is very different when you compare acute and chronic. Please do not get confused. These are chronic patients, and again, despite our practice, our clinical practice in wherever we are working at, be careful, because in guidelines, if it's chronic coronary syndrome, 6 months DPT is the new default strategy, and look at the high ischemic or bleeding risk, then you decide how long you give the APT. But for patients with high ischemic risk, later on we'll talk about it. And for long-term antiplatelet therapy, the guidelines are also open to using clopidogrel instead of aspirin. I bring up this, all this much earlier in my presentation, so that when I go through the guidelines quickly, because of limited restraint of time, you know where to focus on. Anticoagulations, we'll talk about a bit more and how to incorporate it. And others they have mentioned, like high-intensity statins, low-dose colchicine is actually class 2A. Another favorite question in EECC, because it's something fairly new, to do mention a bit. Use of SGLT2 inhibitors, yes, and of course semaglutide, GLP-1 receptors as well. So now we talk about steps. Going now into that big guidelines. We talk about step 1, step 2, step 3, step 4. We'll go through this very fast, mention quite a lot and quite thoroughly as well. Step 1, your initial evaluation, standards medical student stuff. Step 2, further evaluation, where you assess the likelihood. And of course, step 3, you talk about diagnosis, estimating event risk. And this is the complicated part, or this is the part where you really look at the evidence and class of the recommendations. So this is very nice, just showing that if individuals with low or moderate clinical likelihood do a cardiac CT angiography. And treatment-wise is, as you can see on this table. So very nice tables. If you have not much time to study for the exams, please look at tables, the colorful tables that ESC has incorporated, and look at all the guidelines, class 1, class 2 guidelines. All the tables are very important if you do not have time to read up word by word. And rationale, of course, you look at certain studies, not a very recent study, but the PROMISE trial actually showed us not much difference in terms of anatomical testing and functional testing, large pool of patients. But we look at Scott Hart trial, although it's 4,000 patients, when randomized to standard care, we realized that actually CT angiography shows a lower curative incidence of death. So go in detail a bit to the studies, but know a bit more on the conclusion of the study. So that will help you a lot. And when we go to tables, there's colorful tables you have to realize and memorize the class 1 evidence. These are very important. And of course, class 3, of course, is a no-no, and you also should know. Here are basic biochemistries, which I'll go through a bit faster. Excuse me. So low risk, again, to emphasize, always do non-invasive. And here, of course, we talk about CT angiography, and so on. So this is a new table. Now they talk about risk factor weighted clinical likelihood, the RFCL, which helps you to estimate or score the patient for obstructive CAD. Excuse me for that. Characterizing your chest pain, scoring the patients, and by all that, you look at here, you have the blue, green, and yellow. This helps you to roughly gauge for men and women. Of course, you're not expected to memorize this, but this is just an introduction to the idea of risk stratification. Transthoracic echocardiogram, yes, you should know. Say that all the imaging, you should know the weakness and strengths as well as when to use it. And moving on, exercise ECG again is recommended in selected patients. And of course, in individual patients with low or moderate risk, exercise ECG is not recommended to rule out CAD if the coronary CT angiography or functional tests are available. X-rays and all that, yes, I'll move on a bit faster from this. Again, focus on CT angiogram. And again, mentioning that stress echocardiography, you have to memorize this when 2 or more contiguous myocardial segments are not visualized. It's recommended to use contrast agents. So they are all class 1 evidence. You have to memorize this because this has been asked in the exams before. There are a lot of tables to know. Then I'm going through the tables similarly as what you see. It's just to highlight so that when you look at the tables, hopefully you remember what I've said and hopefully you know which part to focus on. Because it's just impossible to memorize everything, right? So you have to really understand the topics well and just pick up on certain key points. Here again, you see if the suspected CCS and moderate or high risk, stress perfusion or perfusion imaging is recommended to diagnose, quantify myocardial ischemia or scar and estimate the risk of MACE. So please remember this is a tricky question. All right, perfusion imaging, you use CT angiography, which one should you use in chronic patients? So when you need to go for invasive coronary angiography, radial artery access, preferred, recommended, that is, goes without said. And of course, in patients with very high clinical likelihood, severe symptoms, you need to advocate invasive coronary angiography. And they all obviously talk a lot about functional testing, FFR and IFR, functional severity of intermediate stenosis prior to revascularization. And then again, class 2A, IVUS should be considered. Numbers are important here, 0.8 less or 0.89. And QFR, again, these are very, very important numbers to remember. They might ask in the exams. Here's a very nice table to classify, but I think in interest of time, I'll go through a bit faster. This I've mentioned all, is just to summarize everything, one nice table. Here, again, just to highlight what we have mentioned, the tables, but put it in a more graphical sense, and that if you cannot find any obstructive CAD, identify that patient could have ANOCA or INOCA. Again, very quickly, but identify and know the limitations of your imaging and stress echoes, because when you give a profile of a patient, they will expect you to understand that profile before recommending whether the patient should be for anatomical imaging or functional imaging. And if you move on faster, we talk about non-invasive testing, initial diagnostic tests, again, pretty much a repetition, but identifying, knowing that your patients need to have the risk justification before you suggest or recommend for any functional or anatomical imaging. Here again, it's very nice to see that it's class 1 evidence on how you interpret exercise ECG, stress echocardiography, stress CMR. Remember that they might give you a picture or an image of a stress echo, 2 or 3 images, or even stress PET or stress CMR, or maybe they just give you an MRI image for you to interpret. So images are important. You must not just know the guidelines, you must be able to correlate with images. So you must have some basic interpretation of MRI, stress echo, and PET. And CCTA, you can see here, looking at the percent of stenosis. Everyone is more than 70%, except when you talk for left main, it's more than 50%. This is about aerobic physical activity. Numbers are very important. They ask in the EEC exams about how many minutes per week of moderate and vigorous. This is what they ask. Please memorize this, right? Numbers. These numbers are very important. Might seem very trivial, but it's actually important. And here I talk about anti-anginal. Look at ivermectin. Ivermectin is way down in class 3. So ivermectin is not recommended as add-on therapy in patients with CCS. Be careful with what we practice and be careful what the evidence show. Although nitrates are very long in the market, it is still class 1B and first mentioned as the selection of choice for immediate relief of angina. So please remember this. Again, exams, this came up before in questions. Antithrombotic, antiplatelets, very nice diagram. Now, for the exams, what should we know? This is a very important table. Do not get confused with ACS. This is chronic coronary syndrome. And remember how you should navigate, especially in terms of using anticoagulations with your single dual antiplatelets. And they will ask you questions like they give you a profile, they give you a setting, then they ask you what's the optimal medical therapy, they give you medical combinations. So remember to assess your patient's bleeding risk, followed by ischemic risk, and then you will do fine. And then you'll be able to answer. So this is a very important table. You have to memorize this by heart. And obviously you can see here, long-term antithrombotic therapy in CCS patients, aspirin lifelong or clopidogrel, and both clopidogrel or aspirin is class 1A similarly. And here you can see after CABG, aspirin is recommended lifelong. I know in clinical practice, there are a lot of practices where after CABG, they give dual antiplatelet therapy for quite long. So be very careful, follow the guidelines. Here you see as well in post-PCI patients, no indication for oral anticoagulation is pretty straightforward, 6 months therapy. High bleeding risk, you may discontinue after 1 to 3 months. And stopping the APT after 1 to 3 months of PCI statin may be considered in patients who are not at high bleeding risk or not at high risk of ischemic events. So you see the class of evidence has went down. And if you have the indication for NOACs, in CCF patients with long-term indication for NOACs, then of course, for the table. And obviously after that, patient can remain on NOACs, any type of NOACs for lifelong. If it's VKA, then it gets a bit trickier. I've not seen a question that talks about VKA in the setting of a patient that does not need indication for VKA, such as mitral stenosis or your prosthetic valves. So I don't think the ECC will be so difficult. They will just be basing on the evidence, and they will give you the scenario that you are able to understand before you give the answers. Here's also important. If you need anticoagulation, very, very important that you memorize the timing of this. And of course, they see here that if there's issues with bleeding, they talk about rivaroxaban, 50 milligram in comparison. They talk about dabigatran, 110 milligrams. So these are important. Dosing and numbers are very important here. And in patients with indication for VKA, INR in the lower part of range should be recommended. Same thing of TTT of more than 70%. Right? So bypass and proton pump inhibitors is still class 1A evidence. It's recommended for patients for increased risk of GI bleeding. Lipid-lowering therapy, similarly, and we do know why that it's less than 1.4, more than 50%. It's based on trials by OCT and IVERS showing that there's regression of plaque. So this is important. PCSK9 inhibitor is a very favorite question in ECC as well. So please remember and know your trials for PCSK9 inhibitors and understand your cutoff point as well for LDL. Here, SGLT1 inhibitors, yes, you should use type 2 diabetic class 1A, and here you can see the reason behind it. So these are other evidence. And colchicine, yes, 0.5 milligram daily. Sorry? Okay, so I'll just continue. Remember the dosing of colchicine, here says 0.5 milligram daily. There are times in the exams where they can just ask, can just say 0.5 milligram twice daily. So do not get confused. Do not get confused. The dosing and timing is very, very important. They will ask you in the exams. ACE-ARB, similarly, is important. Informed decision, yes, I'll pass through this. Now, this table is very important. When they give you and they tell you the EF, please know how much the cutoff point is, because in patients with EF of more than 35%, EF of equal to 35 or less, the guidelines are different. So in this case, in CCS patient more than 35, yes, myocardial revascularization is recommended, and they then tell you what kind of, whether it's two vessels involving proximal LV, and you need to advocate revascularization because that's class 1 evidence. And of course, if less than 35% or equal to 35%, understand that you can choose after heart team meeting, but in surgically eligible patients with multi-vessel CAD, the EF of equal to 35 or less, you should use CABG, recommended over medical therapy. And it's class 2B evidence if it's for PCI.
Sorry, Jeremy, if we could start wrapping up so we can move to the discussion, please.
Okay, all right, sure. So I think that's about it. I'll just move on to that. So syntax scoring. And left main disease, again, CBG, low surgical risk with suitable anatomy, it should be class 1 evidence. So all this, I think, is just very, very important because they give you a scenario of 2 or 3 vessels. But please understand whether it involves the proximal LV. They will ask this in the EECC exams. Heart failure patients is straightforward. And yeah, so I think all this is just heart failure. And I'll move on a bit faster because in interest of time, it's a bit difficult to talk so much about in 20 minutes. But of course, in interest of time, your INOCA and ANOCA, just look at the guidelines. Remember your class 1 guidelines and evidence. And calcium channel blockers are recommended for vasospastic angina. So all these class 1 evidence, just remember, in particular your INOCA and ANOCA. So I didn't have time to go through about that. And yes, here again, DS is still recommended over drug-coated balloon for in DS stenosis. Remember that for your exams purposes. Thank you. All the best for your exams. Just a basic tip. I think some prayers before the exams was good. Why I say this? Just about 5-10 seconds, Dr. Aaysha. During my EECC, I couldn't connect to the exams. So please remember to have good internet connection. I delayed about an hour plus. I was so worried and stressed, you know. And then, but they have very good backup and they managed to connect me back. But instead of taking about 3 hours, I took it like 5 hours because of the waiting time. So prepare very well, but pray as well and make sure you have good internet connection.
Right. Thanks very much, Jeremy, for that overview and also the nice tips and tricks. Just want to invite the audience to put in their questions in the Q&A as we open up the panel to discussions. And I think, like you said, it's also important to look at the new updates. Every guideline has this section called What is New, and very likely the questions will come from that. Related to CCS, I think it's the section on INOCA and OCA that is new. And then, as I said before, look into the trials that might be relevant. Jeremy spoke of the PCSK9 trials. I think others related to this, one of them would be CORE-MICA, which defined the importance of defining endotypes so that you can guide treatments in OCA and OCA. Another one that might be relevant again to this topic is revived PCIS2. So have a look at those trials. You don't need in-depth detail. I think just the abstract should suffice. You have to know the main idea. Nobody's going to ask you the number of patients, but just the idea of the trials. Prof. Tan, Shibba, any comments on this topic?
Shibba, you want to go first?
I think it's really been a great discussion, and there have been several eye-opening facts which are there for us, especially as you mentioned in comparison with the guidelines that we have from the US, especially now that we have patients where their LV functions and the stenosis of the vessels when it is a triple vessel disease, a diabetic patient, and it's not involving a distal left main or a tight left main or a proximal LAD. These are the patients where we can now, as per guidelines, consider even for a better results as we have with CABG, or if we are able to look at the ischemic versus other risk, we can even consider the use of medical therapy. So I think defining of the LV functions and the extent of coronary artery disease and the ability to use medical therapy vis-a-vis revascularization is something which is very new and pointed out by these guidelines. So I think it was really a vast topic, and Jeremy was trying to push in. There are so many things to be discussed. But yes, I would like to know from your experience again, like, we are in an Asian subset. How is your use of rivaroxaban in patients with chronic coronary syndromes? Of course, we saw the guidelines which say that for the first 6 months, we are using DAPT, and later on weighing their bleeding vis-a-vis other risks. There was a question recently in the chat box which we were having regarding aspirin allergic patient with chronic coronary syndrome, and the consideration of rivaroxaban 2.5 BD with a single antiplatelet which could be clopidogrel. So, I mean, the real world scenario which we face.
So yeah, sorry, so I just unmute.
Yeah.
So thank you, Dr. Shibba. Yeah, sorry again. I hope I was not rushing too much. I just thought that I better highlight certain questions. Then talking about rivaroxaban and dosing and allergic patients. So I think we all understand that aspirin allergy, we have to be very careful before we label someone as allergic to aspirin. A lot of us, I think, whether for medical, legal reasons, for being efficient or being just, not rushing in time, we just say, okay, if they're allergic to aspirin, we give something else. But I don't think it's so simple. There are a lot of protocols now for desensitization. And it's important to understand that if they are really not allergic, do not label them as being allergic, because other therapies that you give, if you don't have enough therapies, you're giving some suboptimal therapies and some antiplatelets that are actually not studied in the trials. I think a lot of this is clinical practice. But in my case, is aspirin desensitization. Another question in the EECC also important, because you have to label your patients properly for aspirin allergy. And if they are truly allergic to aspirin, yes, I guess you can use alternative. Of course, clopidogrel is one, but NOAC per se, I think whether it's mentioned in the ESC guidelines, whether you can use, I guess the evidence is not so strong. But if you don't have, obviously, yes, you have to go about it. And of course, in clinical practice, when our patients are so complicated and they're so complex anatomy and they're allergic to so many things, then it gets a bit more complicated. But I believe, and I'm very sure, in fact, that in the exams, they won't make it too complicated. It's just a profile of patient. They just want to see how
Right.
you analyze the patient.
So, Jeremy, there's also mention in the guidelines about the use of rivaroxaban 15 milligrams, in patients who are on NOACs and when the bleeding risk is high. So that's another point. And of course, we use it when they're having a very high ischemic or peripheral arterial disease risk.
Right. Yeah. In terms of triple therapy, I think the studies have shown for every single NOACs, they've talked about lower doses. Most of us try to give the appropriate dose, the full dose. But I think clinical practice, I'm pretty sure most of us give up the reduced dose of NOACs when it comes to triple therapy, because everyone's worried about bleeding.
Yeah, given the extensive discussion on NOACs, just another point about LV thrombi, particularly in ACS. So, previously, it used to be warfarin, but I think now the guidelines have changed and you are allowed to also give in NOACs. Is this in preference? Perhaps if I can't particularly recall, but maybe somebody in the panel can. Is a NOAC preferred over warfarin for LV thrombus in the setting of ACS?
Did I think that it was non-inferior, Aaysha?
Okay. All right. So this was a very lively discussion, Prof. Tan. Would you have any comments and any pointers given your vast experience, and also because you've done a lot of work with the ECC exam for the APSC as well?
So firstly, I'd like to congratulate both speakers, particularly Jeremy. Jeremy highlighted the tips and tricks of being very exam smart. And being exam smart for EECC exam actually is quite rewarding, because it allows you to focus on the key takeaway points. It makes it easier for you to answer those stamps. So I do help co-write the EGC exams, and just a bit of sharing. The first time I wrote the questions, all my questions were rejected because it was too focused on facts and figures. They wanted the questions to be very on the ground and orientated to the guidelines. So it's meant to be simple and straightforward, and it's not meant to deceive or anything. The problem thereabouts in highlighting a scenario is that I'm telling you a case on the ground. You have to then figure out, based on the guideline, what overrides class 1 versus class 2. So a simple thing like a stem of a gentleman who's asymptomatic, then he went for a CT angiogram, picked up multivessel disease, you highlight the segments. Then the stem can then go down to whether what type of vascularization is appropriate versus what type of therapy is appropriate based on this scenario in terms of medical therapy, what type of antiplatelet, antithrombotic therapy. And then, therefore, the guidelines that Jeremy highlighted in terms of what's class 1 versus class 2 versus not recommended class 3 is then very important and makes it easier for you to then answer a clinically orientated question. So the EEGC is actually a very clinical facing type of exam. It doesn't try to ask you between 5% and 50% relative risk reduction in what trial. Those questions I submitted were all rejected. They are trying to ask you in that clinical scenario most of the time, or this clinical picture, what is the best mode of action? So I think refreshing what Jeremy talked about in terms of knowing the flowchart well, knowing what's class 1 versus class 2 is actually just the key. It's a bit confusing, unfortunately. I think ACS is clearer. CCS is actually a very confusing topic. In terms of, firstly, what is the appropriate risk prognostication test? And what Jeremy talked about was confusing because in CCS, there's one part about less than 5% in terms of the prediction of underlying occult CAD versus the prediction of mortality benefit. So people are confused about which is what. But the guideline is actually quite clear, just that it's confusing a lot of people. So even charts about what ischemic features are considered high risk versus not so high risk, and therefore you need to act on it. All this confuses. But if you study it well, actually it becomes clearer and clearer. So it's worthwhile relooking what Jeremy went through and then relooking each facet. It will take you some time to go through, but unfortunately, CCA is what we deal with day in, day out. And if you're not clear about it, you will make the wrong decision in outpatient practice. So I think it's important beyond exams to go through those facts and figures carefully. ACS is a lot more simple in my mind. A lot of the ACS is a plaque rupture physiology that we need to address a bit more aggressively. The data is more clear-cut in terms of the requirement for revascularization. At this moment, is all should be revascularized. You just have to temper the anti-thrombotic, anti-ischemic agents, balancing bleeding risk. All the flowchart tell you to assess bleeding risk first, and therefore the idea is that bleeding risk will trump ischemic risk. If you assess as high bleeding risk, that will take priority over ischemic risk. And that is just a base idea for all the anti-thrombotic flowcharts for both CCS and ACS. For ACS, you have to be very tempered in terms of truncating your anti-ischemic management because ischemic risk within the first year is high. For CCS, I think once the ischemic risk is high, you don't go too aggressive on those treatment. A quick point about aspirin allergy. I think it's good to, in your own clinical practice, know a little bit more about the terminology between desensitization, between challenging the patient and deciding on alternate management only after you fail. And of course, the timing of whether you do the desensitization before or after angiogram, those are quite pertinent questions for clinical practice to know about before you use off-label alternate agents for stable coronary artery disease. It's very tempting to use ticagrelor and then end up with a desensitized patient on the ticagrelor aspirin for stable CCS, which is at the moment still not recommended. Too many things to discuss, but I'll go back to you, Aaysha, for your last comments. Thanks.
Thank you very much for those really insightful comments. Very useful to know how the questions are also formulated for everyone in the audience in terms of preparing for the exam. So very grateful for this excellent panel. Thank you, Prof. Tan, Dr. Shibba, and also our two really great speakers, Upul and Jeremy, for covering very vast topics in such a short period of time and making sure the correct pointers were made. Please make sure you register for our next webinar, which is on rehabilitation and prevention. That's on the 12th of February. And those of you who will be heading to Busan, make sure you take advantage of the early bird and join us for the prep course, which is a full day course. It will cover all topics, and I'm sure it'll be very useful for your preparation. So thank you very much, everyone, and good night.
Thank you. Great
Good
chatting
night.
to you.
Thank you, everyone.